Well, hi, everyone. Welcome to another edition of Shop Talk. I'm Chad Cook. Today we have Dr. Martha Funabashi, and we're going to talk about her paper titled Definition and Classification for Adverse Events Following a Spinal and Peripheral Joint Manipulation Mobilization. This is a scoping review. Paper is relatively recent. It's 2022 right now. It was published in PLOS One or PLOS One in 2022. And we try to really emphasize the papers that are open access. So this one's open access, you can get to it. Martha, it's great to have you here. Thank you so much for being on. Can you tell us a little bit about yourself, your current role? I know it goes pretty deep, and background as a researcher.
Yes. Thank you. Thank you very much. It's a pleasure to be here. Thank you very much for having me. I have a background in physiotherapy from the University of São Paulo back in Brazil, where I'm originally from. After I got that bachelor's degree, I practiced for about 3 to 4 years in an orthopedic rehabilitation center. And while I was practicing, I completed a master's degree in neurosciences, also from the University of São Paulo. And I also got some additional clinical training in osteopathic techniques. And it was then I started to apply all the techniques that I was learning to my patients that I was treating. And I started to see some really interesting and positive, exciting responses, right? So that got me really intrigued and curious about how manipulation and mobilization specifically worked. And that's when I decided to change areas a little bit. So then I moved to Canada, and where I did my PhD at the University of Alberta in spine biomechanics, and more specifically in spinal manipulation biomechanics. After I completed my PhD, I did a postdoctoral fellowship also at the University of Alberta on patient safety and adverse events. After that, I got a position as a research associate with the Alberta Health Services and working in close collaboration with orthopedic surgeons, doing a lot of clinical studies. And then since 2018, I've been a clinical research scientist at the Canadian Memorial Chiropractic College here in Toronto, mainly looking at spinal manipulation, biomechanics, safety, adverse events, and combining all of these whenever possible.
Well, I got to say, you may be the only person that has had a foot in 4 camps so far with biomechanics, osteopathy, PT, and chiropractic. Well, 5 camps too, but also orthopedic surgeons. So that's awesome. You're going to give a great perspective, I think, on this. We both have a mutual colleague, Greg Kowchuk. He had this wonderful picture of you at AOMP this year, standing in what looked like a big biomechanics lab when you finished your PhD, and it was just a really outstanding picture. So
yeah, that picture was on my convocation day, and it was like, yay, did it.
Well, you decided to pursue a scoping review to look at adverse event definitions and classifications. And obviously this is a twisted mess. And we've seen a number of studies throughout the years that talk about kind of the variability in discussion. Can you give us the backstory on why you decided to do a deep dive, a scoping review in this particular topic?
Yeah, so the story behind the scoping review involves actually another study that we are working on, which is a Delphi study, and I can talk about that one a little bit later. But mainly during my postdoctoral fellowship, I worked on a study looking at identifying adverse events in community-based chiropractic and physiotherapy clinics using an active surveillance system, and that project was called the Safety Net study. And when we were recruiting for that study, there were quite a bit of potential participants that were interested in the study, but they ended up deciding not to participate because they didn't agree with the definition for adverse events that we were using in that study. And that definition was derived and adapted from the literature. So a few colleagues and I started discussing and basically planning on how we could come up or develop a standardized definition for adverse events that is accepted by researchers and clinicians that could be used in clinical investigations moving forward. So we decided to do this scoping review mainly so we are aware of all the potential definitions that are out there.
So Martha, great backstory on that. I see a reason why you went down the road. And if anybody has read this paper, you just wait. There's so much work that goes into it. But can you just refresh our listenership's memory on the difference between a scoping review and a systematic review?
Yeah, absolutely. And that's a very good comment, because systematic and scoping reviews are similar, right? In some ways. For example, they both follow a very structured process. They have a rigorous methodology to synthesize the literature. But I think that the main difference between a systematic and a scoping review is that they will answer different questions. And because they are addressing different questions, there are some methodological differences as well. For example, systematic reviews usually have very specific questions, usually focused on informing clinical practice and policymaking. For example, how effective a certain treatment or intervention is for this specific condition. And because systematic reviews are used to inform practice and policies, the critical appraisal of studies and assessing the methodological quality and risk of biases are very important steps of that systematic review. Scoping reviews, on the other hand, they usually aim to map the literature on a certain topic. For example, clarifying concepts or identifying definitions or identifying what types of studies that have been done on a certain topic. And because of the broader scope, scoping reviews usually don't perform that quality assessment, although they can, but usually they don't. Particularly in our study, we were interested in identifying all the definitions, right, and classifications that were out there. So that's why we decided to go with a scoping review, so that we could, with a broader search, we could capture and combine the evidence that was out there for different professions, healthcare settings, patient conditions, et cetera, et cetera.
So you mentioned broader search, and I'm going to give some perspective of how broad it is. I think you had over 8,200 study titles that you originally went through, and you ended up actually reporting on 98 papers. So I know some people have this false assumption that doing a scoping or a systematic review is easier to do. Can you give some perspective on how much time it took and how much effort went into such a large study?
Yes, and I have to say that I'm very, very, very fortunate that I work with an amazing team in this scoping review. We were in a total of 5 different reviewers, and we all 5 were fully involved with completing all steps, all phases of this review. So title and abstract screening, full text screening, data extraction, and data synthesis. And it took us about 6 months to do all of these, a few more months to prepare the manuscript. So from completing the search strategy to the submission of the first version of the manuscript, it took us 9 months, which I think it's remarkable, given the number of reviewers that we had, only 5, and the numbers of studies we ended up including like 98. Yeah, it was a lot of work, a lot of long days, short nights, but it was totally worth it. We learned a lot, and it was an amazing process. Yeah.
Oh, I bet you learned a ton. Why don't you give us an overview of what you found in your summary in the scoping review?
Yeah, so from the 98 studies that we ended up including, most of these studies we identified provided a direct definition for what they considered an adverse event and how they classified. And by direct definition, I mean that they provided a clear statement of their operational definition or classification. For example, they wrote the sentence, in this study, an adverse event was defined as this, this, and that. Or when it comes to the classification, they also specifically described saying, in this study, mild adverse events were this, this, and that, moderate adverse events were this, this, and that, and so on and so forth. There were a few studies that we identified that provided an indirect definition or classification, meaning that they didn't provide a clear statement for their operational definition or classification, but somehow they indicated what they considered an adverse event. For example, they provided the question that they asked the patient on a survey, asking them about their adverse event. For example, did you experience a worsening in pain after the treatment? So that was an indication. Overall, in terms of the definition, there was no one definition that was widely used and accepted across the board. I mean, we did have some trends in which, for example, for studies that were being conducted by the same team of investigators, they tend to use the same definition and classifications in all their studies, which makes sense. But there was no one definition that was widely used. In terms of classification, most of the studies classified adverse events in terms of severity, but even within that severity classification, there was no standardization or one classification that was widely used as well. For example, some studies used mild, moderate, severe, and serious. Some studies used minor, moderate, and major. Some studies used benign and significant. Other studies used intense and serious. So it was all over the place. We also saw some studies that used a different type of classification that was different than severity. For example, they classified adverse events as common or uncommon, expected or unexpected, preventable or not preventable, so on and so forth. So basically, there was no definition or classification that was widely used and widely accepted across the board. Yeah.
Yeah, I think I read in your paper that they used the terms harms, complications, side effects, and adverse events. They were almost used interchangeably. And I've seen you use adverse events primarily so far in this discussion. Is that the term that you would recommend, or do you think further work needs to be done on that?
That's such a great question. And you are absolutely right. I think all these terms are used interchangeably in the manipulation and mobilization field. And I think what is even more fascinating is that this is not specific to manipulation and mobilization. And even in the broader healthcare field, there's a lot of confusion is not the right word, but there's a lack of standardized definitions for these terms. And I think a good illustration of that is that the WHO, the World Health Organization, they have a document describing their conceptual framework for the international classification for patient safety. In this document, towards the end, they have a table where they provide the definitions for all the terms that they use in that document. And if you take a look at that, most of these terms will have a definition, but they will have more than one. And for example, just adverse events itself, it has more than 10 definitions in that table. And some of these definitions are actually somewhat similar to the definitions of other terms like harms and complications. So I think that generates a lot of confusion related to what term to use and what those terms even mean, right? Personally, I don't have a strong preference per se. I use adverse events most of the times just because it's how I learned about it and how I was trained. I do feel that side effects has a slightly different meaning, but among like harms, complications, adverse events, adverse responses, adverse effects, adverse outcomes, I don't have a strong preference as long as we are using it in a standardized and consistent way. And we all know whatever term we are using, we all know exactly what it means, just so we understand each other.
We just finished a nominal group technique where we incorporated policymakers, lawyers, patients, and clinicians to try to harmonize the language for a consent form, because using dry needling, which is a form of force-based manipulation, But we were stunned to find how difficult it was to harmonize that and to provide terms that were meaningful at a level that the patient could understand, but also not necessarily scare the patient off. And I'm intrigued. You mentioned in your earlier experience that some of the patients were like, no, thanks, I don't want to be part of this. In our consent language, we actually outline how common the potential adverse events are and how potentially serious. Did you see any of that in your scoping review?
Yes, yes, we did. So in our scoping review, we did identify some what we call descriptors for both the definition and the classification system. So in terms of definition, some of the descriptors that were commonly used to define adverse event, like the most common one was what I call an UN word. So it's unexpected, unfavorable, unpleasant, unintended, undesired. So that is commonly there to define what an adverse event is. Another descriptor that was commonly used was causality. So they were often mentioned, for example, adverse events are unexpected events with or without cause of evidence of causality, or whether or not it was caused by the treatment. Severity was an interesting one, but we also found that it was often used to define adverse events. For example, some studies only considered adverse events those that were moderate to severe symptoms. Another descriptor was symptom onset. So how long after the therapy that they started to experience the symptom, and symptom duration. For example, adverse event was an increase of pain or stiffness of short duration, for example. In terms of severity classification, most of the studies used intensity to differentiate between the categories of severity. So for example, on a numeric rating scale, symptoms that were rated 1 to 3 were considered a mild adverse event, 4 to 6 was considered a moderate adverse event, and then 7 to 10 was considered a severe adverse event. Some studies also use duration to differentiate between the severity categories. So for example, if the adverse event lasted less than 24 hours or over a week or anything in between. Some also used the functional impact. So how much the patient's function was impacted. So, and how much it impaired their ability to function on a daily basis. And finally, I think the requirement for additional treatment. So if whether the adverse event required additional treatment or not, and among those who did, what was the level of intervention that they required? Was it just like another consultation, or did they need to go to the emergency room or those kind of things?
Holy cow. I mean, talk about something that needs to be harmonized. That's all over the board. And the fact that you could just rattle that off, it's a good thing that you just published this paper recently, I think, so that this is fresh on your mind. Now,
absolutely.
I do have a question for you, and it may not be something that you can answer right now, but we always hear about how potentially dangerous spinal manipulative therapy is, which is why we report on harms or adverse effects. But in comparison to other commonly used interventions like opioids or NSAIDs or surgery, do you have any perspective on risks related to those in comparison to manipulation?
That is another great question. And I'll start by saying that I am far, far, far from being an expert on adverse events related to medications specifically. The very, very little that I know is basically out of my own curiosity, right? And trying to make sense and understand our data and our adverse event related to manipulation and put them into context, right? Having said that, what I learned is that adverse event rate related to taking aspirin daily seems to be about 1 in 5 people, ranging from mild adverse events like bruising to more severe ones like intestinal bleeding. When it comes to NSAIDs and opioids, they also have a wide range of adverse events. And a lot more on that more severe side of things, like cardiovascular issues, kidney injury, also intestinal bleeding, with opioids having a higher adverse event rate when compared to NSAIDs. When it comes to manipulation, for example, previous studies reported that it is about 30 to 50% of the patients that receive manipulation that will experience some kind of adverse events. Most of them are have mild severity, and they are transient. They usually resolve by itself without needing any additional intervention within 24 to 48 hours. We do have a study coming out soon in which we found a slightly lower adverse event rate in about 21% of the patients who received a treatment that included a spinal manipulation that experienced and reported an adverse event. Most of them being like the worsening pain, soreness, and stiffness that is of mild to moderate severity. We did a few studies in the past, and I'm currently doing a few studies looking at spinal manipulation forces and try to make sense of those forces from a safety perspective. In one of them, we measured how much force went to spinal structures during a spinal manipulation and compared with the forces that went to those structures during passive movements of the spine. And what we found was that the loads spinal structures experience during a spinal manipulation are not that different from the loads that they experience during passive movements. We also did a few other studies where we measured how much force a clinician applied to an adult patient, including older adults, so over 65 years old, during a manipulation, and that was mainly during a thoracic manipulation. And when we compare the forces measured in those studies with the forces reported in the literature to cause injury or damage, like fracture or ligament failure, the forces during spinal manipulation are actually noticeably lower than the forces required to cause those injuries. Now, I want to emphasize to your listeners that since these are comparing different studies, we cannot say that spinal manipulation is safe and won't cause these injuries, right? Because these studies have different samples, they use different loading protocols, different equipments. So these are just to put the spinal manipulation forces into context. And basically, when we are looking at spinal manipulation forces in isolation, they seem to be lower than the forces reported in the literature to cause injury. However, we need to keep in mind that other factors like contextual factors, pathologies, comorbidities, and everything together, and other factors need to be taken into consideration whenever we are talking about risks related to manipulation.
Wow, that was really great. Thanks for that. Let's jump back on your scoping review real quick. You have a very thoughtful discussion. And one of the things that you indicated in the discussion was this: you felt that you needed to answer this question with a multidisciplinary approach. Can you give us perspective on why you suggested that?
Yeah, and as we all know, right, manipulation and mobilizations are manual therapy interventions that are used by several different professions, like chiropractors, physiotherapists, osteopaths, naturopaths, etc., and the list goes on, right? And I think that if the end goal is to have a standardized definition and classification that will be widely used and accepted by all the professions that use this intervention, we need their input. We need to engage them in this process because each of them will have their unique perspective, and we need to take that into consideration to develop the final product, whatever that is. So the final, they can all relate to the final product, and which then I think it can help on how much people will accept and use this definition and classification, which is what we want, right?
Totally agree. Completely agree. So earlier you mentioned working on Delphi. I'm guessing that this Delphi, you're trying to harmonize the definition and probably are recruiting multiple people from multiple professions, but I don't want to assume. Please tell us what you're doing with your Delphi.
Yes, yes. So with this Delphi, we are aiming to develop by expert consensus a standardized definition and severity classification for manipulation and mobilization to be used in clinical practice and research. So we are using an approach that includes people like internationally and all from all different professions. So we had experts from all continents of the world in all professions that use manipulation. So we had clinicians and researchers in chiropractic, physiotherapy, osteopathy, naturopathy, medicine, nursing, et cetera, et cetera. We also had the input from other stakeholders as well, like we had patients, we had regulatory body and malpractice insurance representatives, we had lawyers, students, and others, and other experts. So in this Delphi, as you mentioned, we are trying to get to a standardized definition and classification that we all agreed on. We had a total of 3 rounds of questionnaires, and we did use the definitions and the classifications that we identified in this scoping review in one of the questionnaires of the Delphi. We are still finishing up this study, so hopefully soon we'll have some very interesting and exciting results to share with everyone.
Yeah, and I realize you never ask a researcher what the results are until they publish it. So I'm not going to ask, but I'm looking forward to what you found. So I always ask this question of everybody that publishes a paper: is there anything in the scoping review that you were surprised by?
That is a yes. Yes, I was surprised by many things. And isn't it amazing how much we learn with every study that we do? And I was very surprised with the number of studies that we ended up including. Like when we were planning this study, the entire team only thought about that we would have only a few studies, but we ended up having almost 100 studies that provided some kind of definition or classification. And then with that, looking at all the definitions different studies provided, it was super interesting to see all the range of their definitions, which actually made me think even more and actually get more confused and uncertain about what people mean when they say adverse event. I'll give you an example, like in the scoping review, some studies considered unpleasant symptoms as adverse events. Other studies considered death and life-threatening experiences as adverse events. And those are very two different definitions. So now being aware of that, whenever I read a study that reports on adverse events, but they don't provide a definition, I'm like, okay, so what do you mean here? Are you referring to those unpleasant symptoms, or are you referring to those that are life-threatening, right? So I think I just learned a lot, and it was surprising how many definitions were out there that we were not aware, and how much we can learn with all of those.
Well, I was surprised too when I read your paper. I was stunned. I was stunned that there were 98 papers that reported as comprehensively on it as they did, but it just shows you how much information's out there. And I think it also shows why it's so important to have conversations like this, so somebody in 20, 25 minutes can get an understanding of what the literature, and your 6 months of work can be translated to that. Martha, thank you so much for agreeing to speak with us. If somebody wanted to follow you on social media or reach out to you, is there a way that you can be reached?
Yes, absolutely. They can reach me by email, which is mfunabashi@cmcc.ca. I am also on Twitter with the handle @FunabashiMartha, and I'm also on Facebook by simply Martha Funabashi.
Well, you're one of the last people on Facebook, so congratulations there. Thank you so much again, and I hope we connect soon.
Yes, thank you so much for this opportunity. Thank you.